Hi, everybody. This is Jennifer Blevin Smith with Integral Clinic Solutions, and you're watching my YouTube channel, Navigating the Business of Medicine. Today, we're going to talk about patient cost shares. This is a topic that I was asked about a while ago by a viewer if I could assist with showing how to determine what a patient cost share is. And I'm taking this from the angle of reviewing EOBs, ERAs once a claim has adjudicated at the insurance company. In order to do this, we first need to have some definitions. The first one is patient cost share. What is a patient cost share? It is the portion of medical costs that a patient pays out of pocket for services, and they're generally divided into three main categories. You have deductibles, co-pays, and coinsurance. Something to note about this is not all patients have all of these cost shares applicable to them depending on their coverage, depending on the plan they've chosen. It is very rare to find plans that do not have a deductible anymore, but there are some out there. They're usually self-funded for large employers. There are also plans that do not have copays, but most of them do. And instead of there just being a flat rate for copays, there can be multiple different ones. And we'll talk about that in just a second. And then coinsurance. Most plans do have a coinsurance, even if they don't have a deductible and or copay. So what is a deductible? The deductible is the amount of money a patient has to pay out of pocket before an insurance company starts paying towards any of the services that have been billed. And usually the deductible is applicable once per policy year. Now, mention I didn't say calendar year because every patient is going to have a different beginning and end date for their insurance policy. I would say about 80 to 85% of people do have January 1st through December 31st, but there are quite a few out there, 20%, 15%, that could be October 1st to September 30th or any other random date that they begin and end. It is something that definitely needs to be taken note of when your staff is checking patient benefits at looking and paying attention to that effective date. The deductible is a flat amount. It's not a percentage. So depending on if the patient is going to have in-network or out-of-network services and seeing an in-network or out-of-network doctor will determine the deductible. Usually they're two separate buckets. You have an in-network bucket and an out-of-network bucket. Not all patients have out-of-network benefits, but if they do, they have two separate deductibles. So if they saw a patient maybe for a specialist that's in-network, then those charges would be applied towards their in-network deductible. But if they had to go to the emergency room, let's say out of state, that is out of network, then those charges would be applicable to their out-of-network deductible. And they both would have to be met separately in order for their next set of benefits to come in. Most people stick with their in-network because they get the most bang for their buck. It's most cost effective for them. So that is usually the deductible that most people look at, especially if you know you participate at your practice with their insurance and the plan in which they have through that insurance. The copay is a set dollar amount a patient pays out of pocket for specific services, and it is expected to be paid at the time of service. The copay is an agreement that the patient has made with the insurance company directly by signing up for the plan in which they chose, saying, yes, I acknowledge that I have to pay this certain amount of money up front when I see a doctor, before I can be seen. And that's why it's really important for practices to collect this money up front at check-in, because you are deserved that money and it is something that they agree to when they sign up for these plans. The copay is usually not associated with the deductible. It could go towards the deductible. Depends on the plan. A lot of times anymore, it doesn't. But again, there's so many variances out there of plans and how all of the cost shares work. There could be. And I'll show you some examples of how you would be able to read the EOB or ERAs to know and differentiate between a deductible and a copay, and then also a coinsurance, which is what we're going to talk about next. Now, before we jump to coinsurance really quick, I also want to mention about copays that there's different levels of copays now. There used to only be like one or two, but it's getting more complex. And a lot of times there's at least two, if not three or four levels of copay, depending on the type of provider that the patient is seeing. If they're seeing a primary care doctor, it's usually the cheapest copay. If they're seeing a specialist, it's a little bit more. If they're going to an urgent care, it's a different price. And then an emergency room copay usually exists as well, unless they get admitted and then that gets waived. And of course, again, that is just totally dependent on the plan and the benefits the patient has, but that's the most common you will see. Specialists can be really expensive. I've seen them up to $50, $80 to see a specialist. It's very important that you understand in your practice what your taxonomy is, what your contract is with those payers, so that you can make sure that you're collecting the correct copay amount. And you also want to make sure you're not over collecting. For example, a doctor who is primary care at the insurance company through the eyes of the insurance company or general practice type situation, even though you might be an urgent care, if your contract shows that you're primary care or general practice, you would want to collect the PCP copay and not the urgent care copay. It also depends on the place of service in which you're billing. So if you operate an urgent care and a primary care office out of the same location, and you have some established patients for primary care and others that can walk in for urgent care, you'll be most likely billing two different places of service based off your contract. And if that's the case, then you would need to know if you're going to be billing at the place of service 20 for an urgent care, you collect the urgent care copay amount. And if you're billing and seeing a patient for primary care with place of service 11, which is a doctor's office, you would collect the PCP amount. You need to have somebody in your office that understands this, understands your contracts, understands your billing, so that they can educate and train your front desk accordingly, so you don't undercollect, but you also don't overcollect and owe patients refunds. All right, so coinsurance is a percentage. It's not a flat amount like a deductible and copay is. And it's the total charges for a service date minus the contractual adjustments, assuming that you're in network and contracted with their insurance plan. And it's the amount the patient is responsible for paying out of pocket. The coinsurance generally applies after a patient's deductible has been met for the policy year. Deductibles start over every policy year. So now that we're in the beginning of 2024, most of your patients' deductibles have probably started over, which is something definitely to note, remind your front desk, etc., and to be paying attention to those ERAs, EOBs when they're coming through, because that means that you're going to be relying on patients to pay your bills essentially before the insurance will, because they have to hit those deductibles. In the rare occurrence that maybe their plan didn't start over with the first of the calendar year, or that they don't have a deductible, they're most likely going to be responsible for a coinsurance. And the coinsurance is a divided amount. So usually it's an 80-20. You'll hear an 80-20 plan or a 70-30 plan, and that's telling you the percentages. The 80 is the 80% the insurance will pick up after the contractual amount is removed from the billed charges, and 20% would be the patient responsibility. Same with the 70/30, 70% the insurance will cover and pay, and 30% will become the patient responsibility. Usually this is a lot less money out of pocket for the patients compared to the deductible, and they're always happy when they hit their coinsurance, but they still are responsible and will be receiving statements. The only time a patient should not receive a statement is once they reach their out-of-pocket maximum for the policy year. Now, remember, all of this is based on a policy year. It's not cumulative for as long as they're on this plan or have this insurance. It all starts over. So maybe they had the same insurance last year, but now we're in a new year, their deductible starts over, and they maybe have a different amount of copay. Maybe it's gone up, maybe it's gone down. Things that your front office should be paying attention to. But once a patient has paid their out-of-pocket maximum, which is literally the most the insurance says that the patient is responsible for paying out of pocket per policy year, they no longer have to pay anything. They've exhausted what they have to pay, and the insurance picks up 100% of that. And you will notice that on your EOBs, ERAs. It's not super common, but it does happen. It's usually for people who are chronically ill or have some huge catastrophic thing that happens in the year and they've had to go to the doctor, been hospitalized. Not good things usually cause somebody to meet their out-of-pocket maximum. And depending on what specialty you're in, you might see it a lot or you might not see it very often at all. But it is something to be aware of, because once that patient hits that out-of-pocket maximum, they no longer have to worry about a deductible, copay, or coinsurance for the rest of that policy year. All right, so we've gone through this. If you have any questions or comments about these definitions, please leave that in the comments below. Now, really quick, I'm just going to do a quick screen share and explain to you how to identify where the patient cost shares are on these EOBs and ERAs that will be coming into your office. This is a really nice website, freemedicalbillingtraining.com. I just kind of came upon them as I was searching for examples to be able to show you. And I feel like it would be beneficial for you to check this out if you're interested in doing a deeper dive or having your own hands-on to this screen. So I will put the link in the video description for this video. But they provide a lot of samples for you to look at and kind of get used to reading these things. And there's no PHI, it's all test and sample information, so you don't have to worry about that. It looks like they have lessons, so that is something to take advantage of, especially if you're new to medical billing. They describe what an ERA is, what an EOB is, which I have done videos on that as well. There's manuals in here, so definitely check out this free resource. Free resources are always good. So here's an example of an ERA, and you can see that it just tells you what will be in what places when you receive these. Now, please make a note, all insurances have different looking EOBs and ERAs, but they will have the same information somewhere on here. So this is the patient right here. You can see all of the columns across the top of what is applicable underneath it. It looks like this would be the claim number. And if you go across, it will have the service date. So it looks like it was July 1st, 2008. It will notate the place of service somewhere on there, so you can make sure that's correct. And then you can look at the procedure, which is the CPT code or HCPCS code, how much was billed, how much is allowed per your contract with this insurance company. If any was applied of this $44.16 that is allowed for this CPT code was applied to deductible, which in this case, it doesn't look like there was any, but it does look like $8.83 of this $44.16 is going to a patient coinsurance. Now, it does have a CAS code next to it, the CO42, and usually at the bottom of all of these ERAs or EOBs, whether it's paper or electronic, you will have a key to identify and look up what CO42 means, which in their example, I don't see that, but you always will have it. And then it will tell you what the insurance is adjusting off, the difference, and then how much they're going to pay. So it really breaks it all down for you, and you just have to go line by line. These codes, CAS codes, and the remark codes are going to be the game changer, because those are the things that are going to tell you what the amounts are being applied to or why. PR, like down here, PR 100, PR always stands for patient responsibility. So you will know that whatever the number is after it, you can look it up and it will tell you. I think 1 is deductible, PR2 is copay, PR3 is coinsurance, if they don't have the corresponding columns. And the other thing to note on here is it will tell you how much your allowed amount is, so you can make sure that it's matching what your contract says, which is always important to be checking as well. But since we're focusing on the patient cost shares, this is how you would identify it. You just kind of have to train your eyes on how to look at these. As you see multiple different kinds coming from different payers, you'll get more used to it. And then you can make sure you look this up. I can tell you off top of my head that CO45 is a contractual adjustment for your in-network status. CO45 is not a denial. It's just how much has to be adjusted off to get you down from how much you billed to the allowed amount. The AMA has a really nice document here that they have to help you understand and read electronic remittance advice. I highly recommend, if you're new to this or you're not super familiar and you want to become more familiar, that you check this out. I will put this link in the description of the video as well. But you can see that it gives you the basics, the anatomy of an ERA, codes, and if you scroll down, it tells you about how ERAs are organized, and they all might be organized a little different, but you'll always find the same information somewhere on the document. So you want to understand what these mean and what information is on an ERA so you know what's on there. Here's that CAS code I was talking about, the reduction or denial reasons. There's remark codes. It's very helpful. So I would definitely encourage you to look at this document, bookmark it, and reference it. It looks like they did a really nice job. It's older, but that doesn't mean it's not still applicable. And then lastly, I just have a few other examples here of an ERA screen display. And this is a little bit different than the other one I showed you because everything is different, especially if you have a billing system that brings in things electronically from the clearinghouse. Depending on how that's formatted, that's also going to look different too. So you just have to get used to how yours is going to be the way you do it. But here you can see that it's the service allowed amount is in this column. This looks like it has separate columns for deductible, coinsurance, total patient responsibility. It gives the adjustment code, reasons, and the payments. These are the basic things you're going to be looking for on EOBs and ERAs to help you identify what is patient responsibility and why it's patient responsibility. So definitely check out the 2 resources I'm going to put in the video description. Let me know if you have any questions or comments on this. I hope it helps. As always, please smash the thumbs up button if today's video was helpful. Subscribe to my channel if you haven't already, and share this with any of your colleagues, friends, anybody in healthcare that you feel would benefit from this. Thank you so much. I hope you have a wonderful day. We'll talk to you soon. Bye-bye.